This case involves a 48-year-old gentleman who presented to his local physician complaining of some back pain and some right flank pain, and was found on evaluation with a CT scan to have a large right renal mass, as well as significant retroperitoneal adenopathy and evidence of a mass on his left adrenal gland, as well as a lytic lesion in his T9 vertebral body. This is very suspicious for renal cell carcinoma on presentation at stage 4 metastatic. Because of the presence of the lytic lesion in his T9 vertebral body, palliative radiation therapy was performed first after a biopsy confirmation of the renal cell carcinoma. Following palliative radiation to his spine, the patient underwent a debulking nephrectomy, removing his renal tumor out of his kidney, as well as multiple lymph nodes. Pathology from this revealed clear cell carcinoma consistent with a renal cell carcinoma primary and a stage 4 metastasis. The patient subsequently recovered from his surgery and was put on pazopanib, 800 milligrams once daily. He tolerated this pretty well at first. He had some fatigue, some moderate degree of diarrhea that was initially controlled with antidiarrheal medication, and demonstrated evidence of a disease reduction in his remaining adenopathy and adrenal gland. He started this therapy in 2014 and was on it for over a year, over which time he continued to have stable disease. However, over this period of time, fatigue built up, as we commonly see, and episodes of diarrhea resulted in some increased weight loss and worsening fatigue, resulting in a dose reduction down to 600 milligrams. The patient continued to have evidence of overall stable disease, but slow increase in his tumor burden, particularly in his adrenal gland. Then, in the spring of 2016, he started developing increasing back pain. Workup revealed evidence of disease progression in his T9 lesion that had previously been radiated, as well as other spots in his spine, suggestive of worsening metastatic disease. At that point in time, the patient was switched from pazopanib to cabozantinib, 60 milligrams once daily. You know, this case, if I can just comment, I think is atypical in some ways in that this is a young patient, 48 years old, but typical in other ways in that this patient had evidence of a disease that had spread to multiple organs, and therefore was what we consider to be an intermediate risk presentation up front. His response to pazopanib was really exceptional. Over a year of disease control, even with a dose reduction. So really suggesting despite the intermediate risk features, a really robust dependence of that tumor on the VEGF pathway.